Welcome everybody, and we're welcoming our wonderful friend, colleague, and obviously famous speaker, Florence Kaslow, who's a psychologist, has published numerous books and publications. She's basically going to be presenting tonight a wonderful topic that we can all use. We're hoping that every one of us leaves tonight with tools to work with our colleagues, patients, and families. The topic tonight would be working with difficult colleagues, associates, and patients, which, as we shared before, every one of us have encountered. So with nothing further to say, we'll have Florrie take the floor.
Thank you, Angela. I thought it was important to mention at the beginning that this is a group of female doctors, all of whom are in different specialties that cover everything from dermatology, plastic surgery, veterinarian medicine, dentistry, podiatry, psychiatry. Did I miss anybody? Psychopharmacology. I said psychology first. Okay, so we're varied, and it's a group with multiple interests and multi-talented. Okay, I want to start with talking about what makes some colleagues and associates so difficult. And look first at the various characteristics, qualities, and traits. And I'm sure as I'm speaking, you will recognize people that you know. They're usually very argumentative. They're resistant. I think of them as high conflict, and I've isolated what I call the 5 S's. They scream, they storm around, they stonewall. So through their silence, they keep you from saying anything else. And what I sometimes do with couples when I'm seeing them, if they don't understand why their partner can't stand their silence, I'll just kind of turn around and sit like this. And they've never had anybody do that to them. So stonewalling is a very effective way of shutting someone out. And if you have a colleague or associate who you talk to and they simply don't answer, you're stuck. There's nowhere to go with no feedback. Swearing, or they're very secretive. You have no idea what they're thinking. They don't show anything. Some people are always right, and they're very controlling. Now, with the secretive, we often fear that they're deceptive. And so we have colleagues who are deceptive and dishonest. I'm bothered by those who are rude, critical, and mean. And certainly with much of the younger generation, we often see people who were raised not to be particularly polite or civil, that they have been raised to feel entitled, and they're not taught how to behave properly in a professional situation or elsewhere. They can be aggressive and combative, unresponsive, often rigid and stubborn, and very demanding. They may be bossy or dictatorial. And then there's a group who are surly and very disagreeable. Then there are the ones who are cold and withholding. They sit there like this, and you know that. They're like holding themselves in rather than being open. Sometimes we have associates who are angry and hostile, defensive, and the ones who are self-righteous. It's never their fault. They assume no responsibility. You know the people who are critical and negative. It's like, oh, here we go again. What are they going to pick on today? Then in the financial realm, we have colleagues sometimes who are very extravagant. Let's buy this, let's change that, let's expand the support staff. And at the other end, we have colleagues who are financially very cautious, and any expenditure for a ream of paper is too much because they can't take as much profit. So either extreme can be detrimental to your well-being. Then we have the group who are highly competitive, argumentative, negative, so I've added here pessimistic. Today in this era of positive psychology, people who are negative are even more bothersome because we know that that's very stress-inducing. Insincere, they're charming on the surface, but they don't mean it. Belligerent, dishonest, and I've added in not trustworthy. And then there are some people that we meet and may inherit as colleagues who are downright obnoxious. There are people who are intrusive, who do not accept responsibility for their own behavior. And is there one of you who hasn't felt exploited at times by colleagues or associates taking advantage of you? Then there are the sarcastic people who can't say anything nice. There's always that little twist. And sometimes we have colleagues who are power hungry, who want to always do it my way. Others are difficult because they're avoidant, haughty, inaccessible, stubborn, and today I thought I would add in grumpy and irritable. Now, does anybody not recognize someone like that? Can anybody add into that or give us an example of how you've had experience with a colleague with those characteristics? You both said before we started that you had let someone go within the last few weeks. Would either of you be willing to talk about it? Okay, please, Jana.
I had somebody that was working with me from July till just last Thursday when I terminated her. I didn't fire her, I terminated her. And it really was just a matter of that she was an idiot. And that's one thing I noticed that you didn't have up there, that they were an idiot.
She was what?
An idiot. She
Stupid.
had plenty of time to learn her job, be told over and over and over again, and I felt that she was extremely difficult because I gave her lots of opportunities to redeem herself, and I believe that I fell into the trap of assuming that she would get better, but she didn't, and finally I just couldn't handle it. I was under so much stress because I was constantly trying to clean up after her messes. And I should have let her go many months ago, but for various reasons I didn't. And my office is so much happier now, even though we're hustling because we're one man down. The bottom line is I'd rather be one man down than trying to clean up her mistakes.
Thank you. Okay, one of the things that I will be touching on is perhaps how we can avoid those kinds of situations and terminating as quickly as you realize it, rather than saying, I hope it will get better. Okay, part 2. The type of colleagues and associates who present major challenges. And I'm getting in very briefly here to the personality disorders in the Diagnostic and Statistical Manual. These are the Axis 2 personality disorders. And as a group of people when they are our patients, they are really the hardest to deal with. And when we inadvertently hire them or are thrown together in a group and herd them, they may be initially difficult to recognize. Many borderlines, especially the bright ones who get through graduate school and medical school, have a great deal of charm, and on the surface they're delightful, and they can be deceptive for quite a while until the pressure of working with them on a daily basis. So the borderlines, the narcissist, this is the group that are entitled, and it's all about me. I want it my way. The histrionics, they fly off the handle. They get angry easily. They act out. Then there are a certain number who are antisocial. They really don't like other people very much. And they may have done extremely well in graduate and professional school. They're good researchers. They can study well. They do absolutely fine on objective tests. But they don't have a good bedside manner. They're not good with patients. They're not good with colleagues. Then another personality disorder is a person who's highly passive. They're going to just coast along. You can carry twice as many patients. Everything is, why don't you do it? They'll let you take the initiative, but they want the same amount of salary to draw. Then we have the OCDs, the obsessive compulsives, who are also perfectionists. And again, they may do very well in school. They do all their work on time, and it's always very neat, very orderly. Their offices are beautiful, but you can never quite please them. And one of the things that I know when I'm dealing with an OCD patient, even if they initially seem to be in fairly good shape, is when I feel the need to make sure everything on my desk is in perfect order and that I look exactly right when so-and-so is coming in. This is probably someone with a lot of OCD, because they will not be able to relate in the session if not everything is perfect. They're distracted by any disarray. Now, when you live with that kind of a colleague, it makes life very difficult. You simply can't measure up to their standard. Joanne, you're nodding. You've had a partner like that? Please.
No. There are patients that are like that have unreasonable expectations, and they are difficult to work with. So I would be interested to know how you deal with people who have those kinds of expectations, because they're so perfectionist. So maybe we'll get to that at some point.
Okay. Another group of people are very dependent. Often the passivity and the dependence go together. And although they may love that you take the initiative and you run with the ball, after a while you want them to carry some of the responsibility and take some initiative. And finally, we have in this group of personality disorders the schizoid person, who can function reasonably well except under pressure, and they really withdraw into themselves. They're not schizophrenic, they're not mentally ill, they're just very drawn into themselves, and they don't have good social skills. And they're very hard to work with. Some of the difficult behaviors are the withdrawn, the closed kind of behavior They don't participate. And if you're the kind of person, as many of you are, that are bubbly and outgoing, they often can end up making you feel at the same time that they want you to take the initiative, like if you didn't talk so much, I'd get a chance. But if you're quiet, nothing happens. All right. Now, other types of colleagues who present major challenges are those with other kinds of disorders, the major mental illnesses. And as you know, if you have a colleague who's truly manic, they're off the wall. And they come in and they're happy and let's go. They want to overspend and everything is too high. At the other end are the people who come in and they're so depressed and every day is a different thing that has gone wrong. Then we have those who are bipolar and they swing. I remember a case where some years ago I had a female attorney coming up from Miami and she came in and she said, look, I know my diagnosis. I'm manic. I want to stay that way, which is why I picked a psychologist. I don't want medication. So I said, what are you here for? She said, I want you to help me live better with being manic so I can deal with my husband and my daughter. But she said, I want you to know I'm one of the best lawyers in Miami. I can stay up and work on writing briefs 48 hours at a stretch. I can outdo any other lawyer when I go into court because I have enormous energy. Don't take that away from me. And she lived her life being manic and had a wonderful time, but wouldn't touch medicine. But can you imagine having an associate that can keep going and going and going? No matter how much you have healthy energy, that's exhausting. It's overwhelming. Okay. Severe anxiety disorders. If you have a colleague or an associate who's anxious about everything, that is very taxing to live with. That again goes at the major mental illness. That's an extreme form of the OCD very often. But it can be social anxiety. It can be various kinds of anxieties. And then we have people with cognitive thought disorders, and so they misperceive. And again, having a colleague like that, you never quite understand what they're thinking or where they got the conclusions that they did. And finally, if someone has a tendency to paranoia, then they're always going to think in some way you or a patient is out to get them. I added into this the chronic physical illness, used as an excuse or rationalization. Now today, with the Americans for Disability Act, many more people with all kinds of disabilities are going through medical school, law school, psychology graduate school, the other programs. And there was just a case one of 2 blind students saying they were not given the assistance that they needed to get through a graduate program, and they won a huge settlement. The question then becomes, as we help in this way, what does it do to the practice, to the patients? How do we make it a positive, not a negative? And how do we balance the rights of the disabled with when they overuse it and have a legal club over our heads? Does anyone want to comment on that? Because I think that's going to be a growing problem of people pressing charges that I didn't get the job, I didn't keep the job because of a disability or a handicap or a challenge. Anybody? Carol, you want to come in on that?
One of the ideas that comes to mind is the transgendered population and the difficulties that people are going to have probably as the people's, transgendered population steps forward and are more overt and other people have to adapt. It's not quite a disability in the sense that you're talking about, but it's going to be another challenge legally as well as otherwise.
Anybody else on that one? Okay. Now, I'm going to try and go a little bit faster. Also presenting major challenges are colleagues who are not invested in the practice, inattentive and not committed. They don't attend staff meetings or do so irregularly. Work assignments are not produced on time, incomplete, inaccurate, miss too many work days, come to the office late, leave early. Let me double back. I had missed major challenge page. Those with addictive disorders. Again, that you may not see initially with the alcoholism, drug addiction, gambling, sexual addiction, and today an increasing number with internet addictions, including pornography, sitting at the office, going on the internet, pulling up pornography screens. And I put overeating in as an addictive disorder. So all of these that may not be obvious when you're first hiring, and I'll get to that. Okay, now we all have had colleagues, and certainly if we think of backup staff who take and make too many personal phone calls, and that's changed with the cell phones, because the cell phone's in their pocket, they think you're not looking, and out comes the cell phone, or you hear it ring. Sending personal emails or texts on office time, or preoccupied by personal issues on office time. Now, how do we avoid this? And I think that if we can avoid it before we hire or link up with people who are not good for us and for our practices, that's really what we have to try to do. So, who conducts the interviews? How do you cross-validate the information and the impressions? Checking references. Now, sometimes somebody looks very good, they've been recommended by a friend or colleague, and so we don't go far enough on checking. We really need to. And Susan, I know that you're very good about doing other checks on things. And more, I'm hearing people say, I've had a PI investigate them. And years ago, none of us would have thought that. The other thing is today with, I had just written an article, I think some of you saw, on ethics on the internet. And the graduate schools and some of the medical schools are now doing checks of Facebook and other sites before they take the students in. I think we need to do some of that in our practices, but one caution or caveat, they need to know you're doing it. Don't do it without telling, because again, be upfront and honest, which you expect from them. And last year, a friend of mine, who's chair of the Department of Psychiatry and Behavioral Science, called me and he said, we were down to offering a position, we've done a lot of screening, to an associate chair. And right before we offered it, we ran a second check and we found that he had a criminal record. And he got this far. And I said, why didn't you do that before you were ready to make the job offer? And he said, we don't think of people in our field as having that kind of background. So do your checking before you make an offer. not after. Yes.
How do you feel about psychological testing? Do you have some recommendations
Next page.
on exactly what to test for?
What kind of interview and evaluation? And on the interview and evaluation, I suggest that more than one person interview. When I used to interview for admission to graduate school, we always had 2 or 3 people. And if possible, if your practice has men in it, men and women will pick up different things on interview. Secondly, should there be use of a psychological test? I think so, because you can get some objective data there, and the MMPI and the 16PF are 2 of the more standardized and easier screening devices. Now, in your own field, you may have others, but remember, if you have that done, you want somebody who's good at testing and interpreting. These are validated norms, and you can find that they often have norms for our particular field. What would somebody look like in your field that looks good? Okay, so yes. Now, some other things. Observation of a trial session with a patient. If your office is set up with a one-way mirror or an observation room. And when I was teaching at a medical school, we used to observe our students doing therapy. Now, it was a training institution, so patients who came there knew that they signed off, because you don't do that without their being told. But often the students said, how can you observe us when we haven't observed you? So they were entitled to observe their profs. And I think it's important that when we're hiring somebody, if we can in some way observe what they do, don't just tell me how you conduct your practice, show me. Now, not all practices have that. So can you sit in on a session with them? Can you do what I'm being asked to do? Ask them to submit a videotape, a YouTube uplink, or an in vivo demonstration. You want to see what they're like in practice. Now, you also want them to sit in on a staff meeting. And on all of this, there are confidentiality issues. So you want to make sure that if patients are being interviewed with others watching, that they sign a confidentiality statement, that they know it's not just them and the person interviewing, but this will be shared with whoever else it will be shared with. And one of the other things, and now I'm speaking as a forensic psychologist, that I learned early on was you not only want them to sign that before you do before the session, have them sign again at the end of the session, because sometimes things come out in the session that they do not want somebody else to see. They have the right to say, I don't want anybody else to see it. Protect yourself. These are the things that keep you from being sued. Unfortunately, I never was when I was doing this kind of teaching, because I was very strict. Nobody watched over a one-way mirror until we had the signatures. We got them again at the end. And also, if anybody knew the patients, they had to leave. They could not observe anybody they knew. Protect yourself all the way. Okay, now, take those who are serious candidates out for lunch or dinner with other colleagues. Perhaps also your personal partners. See how they fit, their level of comfort, their knowledge of social decorum, and their ease in new situations. Universities and med schools do this before they hire faculty. They really put them through a day or two of intensive social screening as well as academic screening, presenting a lecture. You really want to know who you're taking on. You're going to live with them 5 days a week, maybe 6, and very intensely. You want to make sure what you're getting. Now, consider using an expert or consultant to meet with and screen candidates when you reduce choices to the last 2 or 3 to evaluate and make recommendations. And I've done this for several medical practices here. And when I did this, I'm thinking of a particular OB gynecology practice. And they sent in 2 or 3 candidates. And when we narrowed it down, I also wanted to meet with the man's wife because it meant relocating. And a spouse can be good about relocating or can drag his or her heels and not want to do that. And I suggest that they not only go out to lunch or dinner with the person they want to hire, but with their spouse. How are they both going to fit with the practice and the other spouses? So this is a very serious matter. Okay, now, Jana and Lisa, with these people that you didn't retain for long, did you hire for a probationary period?
I had a little bit of an unusual circumstance. I usually do hire for a probationary period, 90 days, and then we decide whether we're going to up your raise to what we had said we might pay you, or whether we're going to get rid of you. And unfortunately, my office manager was in a situation where her husband was going to be having a knee replacement, and she didn't want to get rid of this person because she needed that extra staff. And we don't have a big office. We have a small office, and so we needed the extra body there. And quite honestly, it would have been better in the long run to have gotten rid of her and, you know, cut bait and get somebody else early on. But finally, it just got to the point we dragged her along until both of us were so stressed out. And I said, I can't take it any longer. And but typically I do. I mean, that's always the way that it has been in my office. And in fact, one of the things that I like what you say is to have somebody else do the hiring. So our next person, I have a very good friend that's very much into management, and she has done, the 2 people that have been fantastic in my office were hired by this one person, a good friend of mine, and who has been in management and interviewing positions. And so she is going to do all my interviewing process and for this next person. So I hope it works out. And instead of just doing a probationary, we're mandating that at least a week or 2 weeks of an internship, no pay. She comes in, we see if she likes it, we see if she likes us and we like her, and she likes the way that we run things, and we'll see about that, because you know, sometimes people look good on paper, they look good at interviews, but they don't work out. So,
Okay, I certainly go with 90-day, 3-month probation, and the final hiring has to be by the people who will be working with you. No matter who you have do the screening, the hiring has to have the compatibility with those who are working with you. Now, very clear employment contract. Yes, Carol?
If you have the co-workers involved with the hiring, what if you have division in opinion? How do you placate the person who doesn't want to hire the new individual when the majority do?
It depends on the power alignment in the practice. And I would say if it's like a 4-to-1 feeling, and you'll have to consider seriously what the objections are. But if this looks like the best candidate to 4 out of 5, then I would probably go with it. A 3-2 split, I'd have more concern, right? With graduate school interviewing, you tend to have 3, and you go with 2 out of 3, unless you have enough students, which most of the schools do today, where you have agreement by 3 one way or the other, right? But you can't always placate. You have to say the majority or the overwhelming majority feel this is the best candidate. And we can't always have our way, you know? Okay, the importance of the employment contract. And I've always had that drawn up by an attorney, review it before each new employee so that it's up to date. And it has to elucidate all of the expectations above and beyond job responsibilities. So that if they're like with some of you, if they have to take emergency rotation, what does that mean? If they have to come in early and cover surgical rounds, whatever are the responsibilities. If you go on vacation, do they cover? What is all entailed? Now, I've gotten as specific as specify if there is a dress code. In many offices we go in today, people do not look what I consider appropriate. Do they wear uniforms? If not, what's the dress code? Do they call in if they can't come in? And it's sufficient time to change the schedule. Overall comportment. How do they relate to the support staff? Are they kind and nice to support staff? Or are they arrogant and superior? Do they show respect for others? The attitude toward patients. And by the way, on this one, and I don't have it in here, what do your support staff, receptionists, call patients? In recent years, I see that many of these young girls immediately call patients by the first name. And not all patients want to be called by first names. I don't. Certainly not by someone much younger who I don't know. And I think each office has to decide what's the policy. Do we start with Mr. and Mrs. or Doctor or Reverend or whatever the person's title is? That's a mark of respect. They are your patient. And then if the person says, you can call me, whatever, but that what do we call patients should be discussed. What's the image presented in the community of themselves and the practice? I'll never forget a night that we were out dancing at a local place where we dance, and somebody came in the next day and said, I don't think you ought to dance like that in public. And I'm thinking, first of all, I didn't see anyone there I knew, but we have to have some personal time, something you were talking about, on a Saturday night to be able to go out and dance or do whatever we do. How do we present ourselves as long as it's reasonably professional, or do we have to go out of our community to have fun? Okay, attendance at weekly meetings, staff meetings, meeting with their supervisor or mentor, and build in a feedback and evaluation component as you go along. Identify what you see as the negative interaction cycle and ask what their observations are. If you're having a problem between you, what's the problem cycle? And show, if possible, the reciprocal nature of the process and model attentive listening and allowing to finish sentences. Comment when they don't listen. And it's okay to say, you know, I noticed you have a habit of interruption. Or you seem to do very well at finishing my sentences. And if you can do it with some humor, but we've all had staff that do that. They know it all. Determine if those involved can acknowledge the feelings beneath the behavior, and sometimes it's detrimental to do that. So you want to know when to steer clear of going into something too personal. Now, if you're in charge, don't abdicate your responsibility. And sometimes we have to fall back on, look, this is my practice, or I'm the senior partner, and if we disagree, we can try and work it out, but if not, I have the final say. And I think that's hard for many of us to do, but it's got to be done. Anybody have a problem with that? Okay. Now, are there alternative ways of coping with work and relationship issues? What else might you do? And can you set goals and implement the changes? In other words, you have 2 months through your probation period. There are some things that aren't going well. Let's look at what has to change in the next month, and how do we do this? How do we accomplish it? Okay, now, it can be important to have somebody say, I want, I think, because when we make I statements, we own what is ours rather than accusatory you statements. But again, sometimes you have to say, you are not measuring up, and we need to know, how do we differentiate? Intercept projective identification, and that means blaming somebody else for your behavior, putting it out. And very often our staff can turn things around and say, but it's your fault, or you do the same thing, and you need to intercept that. We're talking about your behavior now and what you are doing or not doing, and we need to look at that. You're the one on probation, I'm not. Okay. Now, if you cannot overcome the stalemates, the conflicts, and the animosities, consider termination and exit routes. Now, if the associate is a partner, is there a buy-sell agreement? And when you take partners, it's very important to have buy-sells. What percentage of the practice are they buying? What's the sell agreement? At what rate will it be? Does someone estimate or evaluate what the practice is worth? What's their share, and what's the buyout? In the original contract, is there a restrictive covenant regarding the geographic distance in which they can locate? And it's often hard to have those restrictive covenants honored. The law does not do very well, at least in this geographic area, upholding them. What are the other issues that need to be handled? And once you've made up your mind, do not procrastinate. If they have to go, cut your losses, cut theirs. And I assume you all have an attorney that you can turn to for issues like these. Now, dealing with difficult existing colleagues, you want to see as they're exiting whether you can reach some agreement about not denigrating the practice and ex-colleagues after they depart, because that's bad for them and it's bad for you, and it often happens. They probably should be saying something like, I left because we were no longer compatible, or I wanted something different. It just didn't work out for all of us. And not go into detail. People often talk too much, and it's not good for them or for you. Resolving, to whom do the patients belong? And that, at least in psychotherapy, is a very difficult question, because the relationship is with the therapist, not with the practice, from the patient's point of view. And they often want to go with the therapist. And so the question then becomes, whose choice is it? Does the patient have a right to choose who they stay with? The practice getting transferred to a different doc? Or if the other person relocates, in the same area or close enough outside of the restrictive covenant area, whose choice is it? And you may want to think about that before they come on board. Now, if the person departs somewhat precipitously and they haven't talked with all their patients and you haven't, how do you notify the patient? They should be notified, so-and-so has left the practice. You have a choice of going with them or staying with us, or Dr. So-and-so is covering their patients. Does anybody want to add to that or disagree with that? Because the patients have rights to make their own decisions too. Okay. Portrait or model of satisfying practice relationships. This is what we all hope for. Mutual trust and respect. Strong mutual commitment. Considerate, appreciative. Have fun together. Have shared values and goals. Agree about financial issues. And I just kind of like to digress for a minute on that. Angela and I shared offices for a number of years. And all of those things applied and still do. We are close as friends, as couples, and working together was always a pleasure. We cross-referred, and we completely agreed on financial issues. That's possible, and it has existed long beyond. So, but I think the shared values are a very important part of that, and the mutual respect and trust. And I think that's what you look for when you're hiring associates and extending a relationship. Okay, now how do we deal with the difficult patients? The patients who are difficult are like the colleagues who are difficult. But in addition, the difficult patients are those who fail to pay bills, including the co-pays, to keep appointments on time, who cancel appointments who don't cancel appointments within the time limits required by the practice. They don't ask questions when they don't understand. They're negative and pessimistic. Their unrealistic expectations about the course of treatment, prognosis, and recovery. Lack of compliance when agreed upon treatment plan, and they seem to sabotage it. We've all had patients do that. You know, they say yes, but they don't take their medicine, they don't keep their appointments, and then they blame you because they didn't get better. Now, I think the setting and surroundings you're all fairly familiar with, the polite receptionist, and what's the policy renames? First, last, ask the patient's preference, and mark it on charts. I don't like to be called by my first name when I go in, and there's a 22-year-old receptionist who says, "Hello, Florence." How dare you? You know, and sometimes that's policy to make you feel at home. It doesn't. How do the rest of you feel about that? Anybody? What do you do? Joanne?
On their questionnaire, they're actually asked what they prefer. So, you know, they have a preference to what is it Dr., Mrs., or their nickname.
Anybody else on that? Pretty much agree? Jana?
The person that was terminated recently, well, we as an office, the standard is to call Mr., Mrs., Doctor, whatever. And if the patient agrees that, oh, please call me Flory, you can do that. But, and this woman was 67 years old that was in my employ. And we had a gentleman that was getting Fraxel. And so she takes him back to put his anesthetic on and says, "Hey, handsome, come back with me." And of course, my office manager just bristled up and said, I mean, she tried to be very polite and not say it in front of the handsome guy, but it's like, that's not what we do here. You've worked here for 6 months. I mean, that just recently happened. And it's like, how inappropriate. So that was one of the many reasons that she was terminated.
So being respectful at all times and not intrusive is very important. Okay, now in dealing with difficult patients, and we all have them, the receptionist should be polite, easily accessible, friendly, but not intrusive. Giving patients forms and answering questions politely. With the HIPAA materials, we've got to give them to it and provide a contract that's easy to understand, explain policies for appointment cancellation, and bill payment clearly. Have patients sign that and give them a copy for their file. Make sure they get a copy so that they can't say, "I didn't know that." They may take it and destroy it, but you gave it to them. Next, try to stay on schedule. And this is one of the things that angers patients the most, sitting and waiting for more than 15 minutes. And so they often become less cooperative. "You kept me waiting, you have no respect for my time," and apologize for long delays. "I'm terribly sorry." And if you're doing surgery and you're delayed, and your office can call patients and say, Dr. So-and-so is going to be late today. Can you come in a little later, or should we exchange your appointment? So the people are not kept. That's respectful. Now, with the really difficult patient, keep your cool. If you feel verbally attacked or criticized, one of the things to do is to say, "I see that you're quite angry or disgruntled. May I ask why?" They don't expect that. That kind of takes some of the steam out, but you're responding well. Do not counterattack or be defensive. Like, "Well, I was caught in surgery." You can say that nicely. "I'm terribly sorry. I was delayed in surgery, and I knew if my staff called you, you were already on your way." All right? But respect their feeling. See if you can agree with anything that they say to break the impasse. Try not to correct overgeneralizations like, "You never have time for me," or "You always run late," even if they are incorrect. Try to avoid arguing. Rather raise questions and lead patient in a more positive, cognitive, and emotional direction. Diffuse the anger. Now, try to co-construct clear goals, determine the outcome, and identify signs of progress and change, as well as obstacles to change. You seem to be doing well in this area or that, but I think that for some reason this isn't going well. Can you tell me about why you're not taking your medicine, why you're not doing your exercise? Maybe I can help you work on that. Use verbal reinforcers, praise and observations for gains and achievements when appropriate. Now, dealing with difficult patients, be tactful but firm about their following instructions. If the patient won't, if they're a bully, you can tell them, "I'm probably not the doctor for you." And you can give them several referrals. You can't just drop them. We all know that. That's abandonment. But you can say, "This doesn't seem to be working well for you." Not for me, for you. And you can refer them to the County Medical Dental Psychological Society that can help them find a doctor who is a better fit. You can say you don't seem to be satisfied with me, and I'd like to help you find somebody that might suit you better. All right? Now, also, learn how to not let people push your buttons. We all have certain types who do, like if they yell at you. Use humor. Do not overreact. Change the subject. And stand tall, that's hard for me, but tall and firm, and look unflappable. Set limits when you need to. And once in a while we have to say to a patient, I'm sorry, you really can't talk to me that way. All right? Consider how others deal with this difficult person successfully and determine if that would work for you. If it is anything other than always giving in, placating, or flattering, because you don't want to do that. All right? Now, considering transfer to a colleague who may have a very different style or personality, and I should add in there, and will, gender. They may do better with a colleague of another gender, of the opposite gender. And confront carefully if there is no other alternative. Sometimes we have to say, I think you're not making progress because you're not following the instructions. What seems to be the problem? All right? If sometimes feels to me like you're sabotaging your own treatment, what's blocking you from following through? You have to handle it. And remember why you became a doctor. No one promised you a rose garden minus thorns. And perhaps count your blessings that you have so few really difficult patients. Questions, anyone?
This person did a lot of stonewalling, as you alluded to. You could talk on and on and on, and she would just sit there with crossed arms and a very stern expression and not respond to anything. No questions, nothing, just complete silence. And you'd keep going and wait for something. But then from there, it progressed to just being more difficult, calling up, and it was such an emergency that the doctor must drop everything and call me right away, but I won't come in to have my pet examined, but I need your immediate attention. And everything needed to be very simple, and yet if things didn't work out perfectly, there was a lot of anger, so unrealistic expectations, and a lot of, I wasn't dealing with this patient at the end, my colleague was, but a lot of abuse towards our other doctor, and our other doctor actually said, is it okay if we fire this client? And we always support our doctors if they make that request, because it's very rare.
Other comments, questions?
I actually have, going back to support staff.
The what?
Support staff
Okay.
problems. Most of the time, we do have problems initially when someone presents themselves to be more than they are, and we see that quickly in the probation period, and we let them go. But with support staff that we have more long-term, it's often rumblings that we don't know about. There's one support staff that is instigating lazy habits or disrespectful habits or even dishonest habits, and we don't know who it is. The other support staff never wants to say anything bad about their colleague, and it festers and sometimes metastasizes through the staff for months or even years before we realize what's going on. And then eventually it will come to a head, and the other staff will be fed up, and they'll say, this is what's going on, you need to know. But is there a way that somehow that could be weeded out earlier?
I think so. What I tend to do in those kinds of situations, and I'm going to ask Angela and Carol if they want to come in on this too, is to call a staff meeting and say, something's going on here that's not healthy for all of us. It's undermining our work. Depersonalize it and say, this is what I'm observing. Could you all help me to understand what the discontent is? And handle it fairly straightforward and say, we need to figure out what's going on and work it out. All right? So you're not targeting anybody, you're talking from your observation. But there are grumblings and rumblings, and it's not a happy environment. And since you're all committed to the work, that's why you're here, we need to improve the environment. All right? I'm very strong on, as soon as you sense that for any length of time, bring it to a head. Don't let it keep going. Angela or Carol, you want to add to that?
I mean, I agree. The longer it goes on, it just escalates, and then it gets very diluted and difficult to sort out. So the sooner you talk about it and bring it out in the open. But I think one issue that we were talking about, which I think is important, is the fact that when you terminate a patient, most I guess boards have guidelines as to what you must do
Right.
to end that relationship. And I know in our profession, the American Psychiatric Association has a strict ethics guidelines that we follow. And that seems to satisfy the Board of Medicine. I'm not sure how that's handled in other disciplines as to when you terminate a patient, do you follow your board or you follow your association's guideline?
Thank you, and certainly any of you need to follow the guidelines in your specific field on how to terminate.
I agree that we also within our society have certain rules of ethics of what we should or should not do, and they're probably very similar. It's just different kinds of patients.
We usually need to issue like a written letter notifying the patient that, well, because of certain reasons, we will, continue your care and coverage for 30 days. And then after that, you can find another physician in the community, and that has to be placed in the chart. And sometimes we call our malpractice company for guidance as to how to discharge this patient, give them the heads up that there's an incidence and they may be litigious, and do they have any recommendations? And we usually follow it with a letter.
Very good. The call your malpractice company for guidance. Carol, do you want to add in anything? Okay. All right. Any other questions or comments? Was this useful? Helpful? Is this okay? I think that the whole issue of difficult colleagues, associates, and patients makes us uncomfortable, but there are times where there are people we really can't work with, and there has to be an exit strategy. Sometimes somebody else in our practice has a very different personality or tolerance for a certain kind of behavior, and so a change can do. But if you're in a solo practice, that's very difficult, right? But you want to protect yourself by calling your malpractice company or your medical society, follow the guidelines, and most of us, I think, have going for us that we really care very much about the people we treat, that we do call colleagues when in doubt, we seek consultation, and we practice ethically. And we have strong support networks like this. And that given that, we really try to stay out of trouble and are very patient-centered. There's no one in this room, I'm looking around again, that I wouldn't feel comfortable referring to. And I think that's for me, that's the gold standard. Would I refer to this person And would I use them for a family member? And if that's the case, or a family dog, that if so, then we know that we're upholding those standards of practice. Okay, any wrap up before we close? Any final comments? Anybody?